Good afternoon. Welcome to UCSF Department of Medicine Grand Rounds. I'm Bob Wachter, chair of the department. Today we have another installment in a format that we've used over the years that tends to be some of our most fun and educational sessions. So this is a clinical problem-solving case with Dr. Nirav Bhakta. And I will first introduce Nirav, and then we'll get to the case. Nirav is an associate professor in the Division of Pulmonary Critical Care, Allergy, and Sleep Medicine at UCSF Health. He went to med school at Stanford, and luckily for us, we recruited him as an internal medicine resident. He stayed for his fellowship in pulmonary critical care medicine and joined our faculty now a decade ago in 2013. He has become one of the revered clinician educators and also does some research in the division. He's the director of education for the UCSF Adult Pulmonary Function Laboratory, as well as the site director and coach in the Pulmonary Fellowship Training Program. And just last week, he was named a Department of Medicine Master Clinician, which is a honor that we give the doctor's doctor in our department. And Nirav certainly meets that, merits that honor. The teaching points of this case, and the case was put together by our chief residents, Fretz and Viridiana Garcia. And so we will go through the case, and then we will have a mystery discussant at the end. Well, I will introduce at the appropriate time to go through the case. So those of you who've been with us for these in the past know the way it works. Discussant has not heard about the case. The goal is to learn from how a master clinician thinks about the case, not necessarily to get it right. They're not magicians. They don't have to know everything, and neither do any of us. We can obviously look up a lot of stuff. It's about the journey and not the outcome. So the real goal is to see how Nirav thinks through a pretty complex case and some of the twists and turns. And we'll have a few audience response questions marbled through the presentation to give you a chance to participate and take a try at an interesting and I think fairly complex case. So with that, Nirav, welcome.
Thank you, Bob. I'm excited.
How you feeling okay?
Yeah.
All right, let's go to it. So there are a fair amount of presentation before we get to your first branch point, but feel free to stop me if you want to have a little more time to go over anything. The case is of an 83-year-old man with a past medical history of coronary disease who underwent a CABG in October of 2022, and the case plays out about 3 or 4 months after that. Has VT, status post and implantable defibrillator, has hypertension, who is admitted to the medical service for an evaluation of dyspnea. So going back a few months, he underwent his CABG in October. He had a post-op course that was complicated by VT, requiring an ICD placement. In February of 23, he presents the ED with 3 months of progressive dyspnea. His evaluation there is unremarkable. He undergoes left heart cath to rule out recurrent cardiac ischemia, which was notable for normal left ventricular end diastolic pressure, patent grafts, except for stenosis in his OM2, for which he got a drug-eluting stent, but that did not seem to improve his symptoms. Now, a month later, he has ongoing dyspnea with symptoms at rest. He notes substernal chest discomfort that's intermittent, not worse with exertion. His review systems, he has no lower extremity edema, no hemoptysis. He does note a dry cough for a couple of months, some loss of appetite, and he's lost 16 pounds over the last 4 months. Past history, as I said already, multivessel coronary disease, hypertension, the VT after his ICD, his meds you see, kind of the usual cardiovascular meds mostly, but includes amiodarone. Past surgical history, we've already gone through, including his CABG in October and the PCI with the stent in February. Family history, some hypertension, social history, no tobacco, alcohol, substance use, no recent travel, born in China, moved to San Francisco more than 20 years ago, retired, but previously worked as a mechanic. On physical, blood pressure is normalish low. He's a little tachycardic, 108. Saturation is 98% on room air, 16 respiratory rate, temperature 99.2. And he looks okay. Moist mucous membrane, nor oral lesions. Cardiovascular, all that's noted is the tachycardia. He has ultrasound with a small and collapsible IVC. I'm still too old to sort of buy the idea that POCUS is part of the physical exam, but such is life today. Grossly normal biventricular function. Pulmonary exam, decreased breath sounds at his left base, no wheezing, few bibasilar crackles, and despite the otherwise unremarkable exam, he's only able to speak in 2 or 3 word sentences, so appears to be somewhat dyspneic. Abdomen benign, skin nothing except for his sternotomy scar, which looks fine. Extremities are warm, no lower extremity edema. He's alert, oriented, and non-focal on neurological exam. So we're going to give you some baseline labs. CBC appears to be normal white count, lights look normal, renal function normal, LFTs normal. His BNP is up a little bit from his baseline at 224. He's got troponins that peaked at 0.13 down to 0.07, VBG with a PCO2 of 46, COVID's negative, RVP is negative, albumin is a little low at 2.8, calcium 8.9, lactate's fine, CRP 71, previously 15, SED rate 39, previously 13. He has a cardiogram that shows sinus tachycardia, some T-wave abnormalities in the inferolateral leads, a few PVCs, but it is unchanged from his prior. And he has an initial chest X-ray that shows a moderate right pleural effusion, a small left pleural effusion, normal cardiac silhouette. His AICD seems to be in the right place, and he has median sternotomy wires. So I have just given you a blizzard of information. So let's stop here and just ask, and I'm happy to go back and take a look at any part of it that you would like, but let's just ask how you are approaching the patient's presentation and how you would be thinking about what to do next.
That was a lot of information, Bob. I think the only one thing that I missed on a previous slide was the VBG. If you could just back up for a second.
I can do that.
As I was scanning
it was a PCO2 of 46 and a pH of 7.46.
And COVID, RVP negative, okay. All right. So we have a 83-year-old man who has had significant cardiac history and care with us in interventions in the last few months, presenting with dyspnea. And there are some other associated features that then develop that are concerning, including chest pain and weight loss. Moreover, the progression to dyspnea at rest when it was present initially with exertion, I believe, is another concerning feature of progression, and then ultimately leading to the presentation here. One of the things that caught my eye initially was the dissociation between the normal oxygen saturation and the significant dyspnea that was associated with only able to speak in 2 to 3 word sentences. And this comes up often in the outpatient, inpatient setting, and we often have to explain it to even patients who may fear that we may not be taking their dyspnea seriously when we tell them that their oxygen saturation is normal. And we will often explain that there are many causes of dyspnea that will lead to normal oxygen levels, even though it's natural to connect the two. And there are cases where a really low oxygen level can be induced and it will not lead to much dyspnea. And so starting from the broad framework that we use for dyspnea of pulmonary disease, cardiac disease, problems with oxygen delivery with extreme anemia or alterations in hemoglobin or really severe metabolic acidosis, and then even taking the pulmonary beyond to a larger picture of the respiratory system to include not only the lungs, but the extra pulmonary components of the respiratory system, like the pleural spaces and the respiratory muscles. Initially, I'm thinking, well, okay, the normal oxygen saturation makes me think less about a parenchymal lung disease, an airspace filling process that will really affect oxygenation, leading this much dyspnea. And it does make me want to think a little bit harder about the cardiac system. We saw that the hemoglobin was normal or normal enough that this really shouldn't be influencing the dyspnea. And he does have a significant cardiac history. So going a little bit more on that, on the cardiac front, even though we have a POCUS, we didn't hear about what's going on in the pericardial space. I don't think that we saw negative data on there being an absence of pericardial effusion or pericardial, other pericardial process like a constrictive or process. And so I want to take a look a little bit more at that. And then at there are pulmonary processes that can lead to dyspnea with a normal oxygen saturation. And if it's not a significant airspace filling process, then there may be a process in the airway, so the development of an obstructive disorder, or perhaps there is a process, limiting expansion of the lungs, a restrictive process, although not severe enough to cause a significant hypercarbia, may be influencing the patient's dyspnea. We did see pleural effusions on that chest x-ray, which are common after coronary artery bypass graft surgery, but sometimes can be persistent and associated with pleural changes, including pleural thickening. And then I also think about, maybe there he's compensating, maybe there's he's able to get his oxygen saturation up. Oximeters are vary by 3 to 4%, and based on skin color as well, we know there are effects, and maybe the oximeter is making us a little bit more reassured, and there is in fact an oxygenation problem that we're not catching with it, and so we can expand the differential then to include airspace filling processes, including things that a chest X-ray might be not very sensitive for, and so he may have still pulmonary edema. He may have amiodarone toxicity. That's one of the medications that we saw that he was on. If that were associated with an organizing pneumonia, that can be associated with over time with weight loss. And then, the chest pain, I haven't worked that in terms of the salient points from the case. But that does make me think, again, more about either a pericardial process or a pleural process leading to the pain.
Great.
And then I think that your next,
maybe before we go on, let me just probe a couple of issues. I don't think you mentioned the pulmonary vascular problem. Is that sort of on your list of things to worry about as well, particularly after a guy had surgery 4 months ago?
Yes. So you're thinking of pulmonary embolism. Certainly he has tachycardia, and the heart is under a little bit of stress. He presented with a little bit of a troponin elevation, a little bit of a BNP elevation. You can have pulmonary embolism causing dyspnea with a normal oxygen saturation, normal hemodynamics as well, and so that remains a possibility.
Okay. And I noticed the one factoid you asked about to go back to was the PCO2. Describe a little bit of the relationship with the oxygenation and the PCO2. Like if you thought the oxygenation was faking you out, as you said, an oximeter is not perfect, but I guess I would also wonder, is it faking you out that he's preserving his oxygen, but having to breathe very hard to do that? Would you expect the PCO2 to be low? And is the fact that PCO2 is not low on the VBG, is that sort of reassuring in terms of there being enough parenchymal disease, whether it's heart failure or amiodarone or something else, that you can't explain the dyspnea based on that because of the combination of a normal oxygen and a normalish or even slightly elevated PCO2?
Yeah, his PCO2 being 46 on the VBG, we, it'd be right to conclude that his arterial PCO2 is normal and unlikely very depressed, although there can be enough of a discordance between the VBG and ABG that he may be bringing his arterial PCO2 down in the setting of this whatever is causing the dyspnea. And maybe given that there isn't a lot of hypoxemia, I wouldn't expect as much of a depression of the PCO2. And so he may have an appropriate degree of appropriate PCO2 for his dyspnea if we were to check it on arterial blood gas. Your other question, in terms of does it, the normal or low PCO2 is reassuring that we don't have a problem with ventilation leading to the hypoxemia. So our ins of oxygen are well balanced relative to the outs being going into the blood to supply oxygen to the body that needs it, and the out in terms of exhalation. And so I think that balance is fine. And so his hypoxemia is then going to be we're going to be thinking that in terms of physiologic mechanism, which may be where you were going, we're going to think about low areas of ventilation relative to perfusion. We're going to be thinking about shunts. And, those are the main two things that we're going to be thinking about. In most patients, we're not seeing a diffusion defect leading to hypoxemia or low inspired partial pressure of oxygen. And so the PCO2 is helpful in getting us towards ventilation, perfusion, mismatch, and shunt.
And last question before we sort of spend a minute on where you go next. You mentioned cardiac. Could it be, he's had cardiac problems or pericardial? Can you get dyspnea from those things in the absence of heart failure? Is the mechanism for dyspnea always that fluid backs up into the lungs, or is there something else that can cause dyspnea in when the pulmonary pressures are fine?
Yeah, I think that this has been looked at, and it's more obvious when there is heart failure, as we might have been seeing on that POCUS, and we didn't see. One, I think the POCUS is a gross assessment, and there still may be a problem with oxygen or cardiac output contributing to dyspnea. On the other hand, just the stretch, it's thought, related to elevated filling pressures in the heart, although there was a left heart cath that showed a normal LVEDP, at least in February. But if there were stretch, say, for example, on the right side of the heart, whether from a PE, or if there was a problem in the pericardial space, I think there are mechanisms that can lead to dyspnea, not necessarily the degree of dyspnea that this patient is having without overt heart failure.
That's good. Good to know. Okay. And for those, there are probably a few people who have not heard the term before. So POCUS is point of care ultrasound. That's an ultrasound that folks carry in their pocket for the initial assessment. Okay. Why don't we go? So give us your quick, what would you do next here?
Well, this patient has a lot of dyspnea, and we don't know what's going on yet. I think he is a good patient to get more detailed picture of the lungs and the heart. And so I think having a CAT scan of the lungs to really look carefully at the lung parenchyma and doing it with contrast to evaluate for PE as well is going to be important. We didn't hear about leg edema to increase our risk for DVT leading to pulmonary embolism, but people can have more central clot or even find PE in the absence of a current DVT. Maybe they had a DVT previously. And so I think a CT angiogram of the chest is going to be important. A formal echocardiogram will be important. I think I'd like to start with those.
Mm-hmm. It makes a lot of sense. Okay. Let's go on. So as you requested, CT of the chest, including a PE protocol, and as you see it unspooled there, no evidence of PE, moderate right and trace left pleural effusions with adjacent atelectasis, and the seemingly ubiquitous ground glass opacities in the right upper lobe. Any quick comments on that? You wanted that, you got it. How does it change your thinking?
The pleural effusion looks big on the CT scan, but by itself, I don't expect it to cause this degree of dyspnea. Now, if the rest of the lung were very injured, either chronically or acutely. For example, if a patient has a lot of emphysema or other process happening in the rest of the lung, then the addition of a large pleural effusion like this can tip patients over into severe respiratory distress. But given this, what we see of the relatively normal parenchyma on the left and the mild disease in the other parts on the right lung, the effusion might be contributing a little bit, but it's not the driver of the dyspnea here.
Okay. All right, so the team wanted additional workup, I think in part now finding the ground glass opacities, and so there's the clinical course. The patient underwent a right-sided diagnostic and therapeutic thoracentesis. I assume you'd endorse that now that you have a decent-sized pleural effusion, you need to see what's in it?
Yep.
Okay. 700 mils of straw-colored fluid removed. Pleural fluid analysis revealed an exudate of effusion. You see the data there, including high protein, high LDH, white count of 525, majority lymphs, red count 4,200, negative gram stain. The ICD was interrogated and apparently looked fine. And so the clinical course, dyspnea persisted after that thoracentesis. As you predicted, it doesn't seem that fluid in and of itself was driving the dyspnea. And a further workup was sent. You see it here, HIV negative, Hep B and C negative, TSH fine, SPEP normal, UPEP negative, procal 0.19, pleural fluid cultures, bacterial cultures are negative. Pleural fluid has large atypical lymphs. So let me ask, this is for the audience. You should have your survey up in front of you. What would your next step in management be? A, you wanted to start broad spectrum antibiotics. B, you think the patient could use a chest tube. C, you'd like a transthoracic echo to see what's going on with the heart. Or D, you would like to diurese the patient and see what happens. Let's go ahead and vote. Give it about 10 more seconds. Thank you. All right, and as you had requested, the majority of folks want the echo. 20% of people want a chest tube put in this exudate of effusion. One person wants broad spectrum antibiotics. One person wants to diurese. What do you want?
Broad spectrum antibiotics. I assume the patient has already gotten these at the beginning of their admission. Often, in the setting of any airspace disease, like we have these ground glass opacities on the CT scan, in a patient who has the potential who's already presenting in severe distress and potential to get worse, is prudent to initially start empiric antibiotics. And then the other, I'm still interested in the echocardiogram. I don't see evidence yet that we need to heavily diurese the patient to get a benefit. And unless the effusion recurs and gets big again, I'm not interested in putting a tube in it right away. What did you say the fluid looked like?
So the fluid was exudative with the straw colored, not bloody, and 525 white cells, 63% lymphs, 32 monos, few red cells, and exudative, at least by Light's criteria. So let's go ahead and sort of ask you how you interpret the pleural fluid studies and how it shifts your thinking at all, if it does at all, around what's going on with this patient.
I think the lymphocytic predominance is something that can hone in on a more selected differential compared to the wider differential for all pleural effusions. Initially I was thinking when I saw these pleural effusions on the chest X-ray that these were related to his coronary artery bypass graft surgery, and that we weren't going to find infection or malignancy or something else in there. The finding of the lymphocytes, it was consistent with the chronic process, and it makes me want to think about chronic infections and malignancy, and then some other things that lead to lymphocytic effusions. You have to entertain chylothorax in a lymphocytic effusion, but the fluid color here was straw colored, and that's why I asked to be reminded of that. Whereas we would expect it to be thicker and often more white milk-like appearance if it were to be a chylothorax. So I think sending it for more cultures in terms of not just a bacterial culture, but fungal culture, AFB, thinking about AFB, I'd like to know a little bit more about this patient's history of tuberculosis risk factors, and we can send adenosine deaminase from the fluid as well to further our insight into whether this might be a tuberculous effusion. And in case we'd be invoking a diagnosis that has nothing or relatively little to do with his recent cardiac history, it might fit together more with this months-long course of weight loss in addition to the dyspnea.
Let me just pin you down to that. Do you ever see patients who have reactivation of infections after an insult like cardiac surgery, or could that be enough to have tipped them over to a state of relative immunocompromise?
I'm not, I don't see that often enough that I think that that's a strong risk factor. Unless he had diabetes that hadn't been well controlled post-operatively, that's one possibility. And so infection, broadening our differential for infection with that lymphocytic effusion is important. And then malignancy as well. I don't recall if you said that it was sent for flow cytometry, but I would send the fluid for flow cytometry, thinking about lymphoma, whether systemically or a primary effusion lymphoma, just in that space. And I think you did mention that there were some atypical lymphocytes that were present on the large atypical lymphocytes were seen.
Just I don't think we know that. I think just lymphs.
Oh, I think it was the next slide. Yeah, pleural fluid.
Oh yeah, sorry, you got it right.
Lymphocytes.
Yeah.
So flow cytometry is something that.
So it raises the probability of this being a malignancy.
Yes.
You mentioned that at least in the beginning you might have kind of attributed this to as being after surgery. Did the fact that it's got a lot of lymphs and the fact that it's exudated that make you think maybe not, that there's an active process there?
Yes, that would be at the top of my list. I think over time, if a post-CABG effusion is long-standing, and especially if it's been instrumented before, but this patient hasn't, and this is the first time, then it can evolve. But at the top of my list right now is thinking about things unrelated to the surgery.
Okay. All right, let's go. Let us go on. And all right, it gets his TTE, which you asked for a little while ago, and folks can see it. RV and LV look normal volume, mild biatrial enlargement. He's got an ejection fraction that's fine, no diastolic dysfunction, moderate LVH, no significant valve disease, and no pericardial effusion was seen on the TTE. His clinical course, he has an ambulatory saturation that falls to 93% while ambulating, continues to report subjective dyspnea and only is able to speak in 2 or 3 word sentences. Is a repeat chest x-ray performed and is notable for rapid reaccumulation of that right pleural effusion, and the procedure team was consulted for repeat thora and performed a bedside pulmonary POCUS, which now is notable for a loculated effusion. Before we go on, sort of, how does your thinking change now that you've heard that it's loculated?
This is consistent with it being longstanding. Makes me worried about infection. Still makes me worried about malignancy. I think as you mentioned, it's possible, given that we're this many months out from cardiac surgery, that it, like I said, it can evolve into a chronic appearing effusion with lymphocytes, development of loculations. And the fact that it has reaccumulated despite thoracenteses and have these loculations also makes me think this patient is going down a pathway of needing drainage, may end up needing more than one tube, but at least initially putting one tube in there, trying to drain the space, and will likely need installation of TPA in order to break up some of these loculations, coagulated blood, and clear the space up.
So your initial inclination a few slides ago was he didn't need a chest tube, but the fact that he reaccumulates so quickly and now has loculations has changed your approach, that he's going to need. Yeah. Okay.
Exactly.
Let's go on. And your colleagues were consulted and recommended a pleural catheter to fully evacuate the effusion, followed by a repeat chest CT after the re-expansion. And so a right pleural catheter was placed by IR, no complications, and drained another 450 mils of straw-colored fluid. No improvement of his symptoms again after this repeated drainage procedure. Vitals notable for intermittent desats now to 88% on room air, and he's placed on a little bit of oxygen. Repeat chest x-rays done with the drained right pleural effusion. It shows improvement in the pleural effusion and persistent trace left pleural effusion. So where would you go from here?
I'm still perplexed by the dyspnea and now hypoxemia, and not yet convinced that it's directly related to the effusion, although it may be connected to a larger process. Now we are seeing the development of more hypoxemia in this case, and so it might be a good time to get a repeat CT scan. It's also when there was some of the lung that we were unable to see because it was compressed right adjacent to the effusion, and it's nice to have a better picture of the lung parenchyma after drainage of the effusion as much as we can. So now that we have a tube in, we're going to see that lung expanded, and we can get a better picture of the lungs. The ground glass, maybe it has gotten worse. And reflecting, more airspace disease, and based on the pattern of it, we might get clues. Is there any evidence that the lymphatics are blocked up, going along our concern for a malignancy, or are there nodules that are concerning for infection? I would get another CT scan at this point.
All right. So it sounds like one of the early mysteries is sort of the dissociation between his symptoms and how he looked and his saturation. That dissociation has gone away. He now has some desaturation and is dyspneic. So that's now consistent, but it's now you're still head scratching about the source of his dyspnea, and you're unconvinced it's the pleural fluid that you've drained it and he doesn't get better or feel better. And so you're back to trying to figure out what's going on in his lungs.
Yeah.
Is that a fair summary?
That's a fair summary, yeah.
Okay. Let's go on. So given the repeat hypoxemia, he has a sort of broader workup. COVID and flu are negative. Repeat cultures of his pleural fluid are no growth. Troponin trend came down, goes up a little bit. CRP continues to go up. STED rate stable, but not normal. EKG continues to have sinus tachycardic, unchanged. Patient's hypoxemia was attributed to pulmonary edema from lung re-expansion after his pleural catheter was placed. He was given a diuretic with some improvement in his hypoxemia, but continued to have profound dyspnea and was unable to ambulate, and has a repeat CT after his pleural catheter and drainage, which you had asked for. And here is this one, mild peribronchovascular and peripheral ground glass in multiple lobes with no evidence of bronchial wall thickening or septal thickening, no reticulation traction, bronchiectasis, honeycombing, or air trapping, calcified and non-calcified mediastinal lymph nodes, no pericardial effusion, and decreased size of the right pleural effusion and continued trace left pleural effusion. ID and rheumatology were consulted, because we're definitely in the head-scratching phase here. We're consulted for recommendations on workup of this exudative and as yet undiagnosed pleural effusion. He has PCR for MTB negative twice, AFB smear negative, pleural fluid culture is negative, no evidence of CMV or pneumocystis. RF-CCP and ANA are negative. Your colleagues recommended bedside PFTs to evaluate for obstructive and restrictive lung disease. He has a MIP of negative 85, a normal peak flow, and as you'd asked, pleural fluid cytology, that is negative, and a pleural fluid ADA came back at 19.4, which is not high. So let me ask the audience what you would do at this stage. It's kind of confusing. You could go for a right and left heart cath. You can get a PET CT. You can do a bronch. You can get a cardiac MR, and you can ask for a pleural biopsy. And let's see what the votes are. And I will go ahead and end the poll. We have a winner. And I don't know if you can see that, but 56% of people wanted a pleural biopsy. Next was a bronch, about a quarter. And then we have a smattering of the other three. A few people want cardiac MR, a few people want PET, a few people want him to be recathed left and right. But pleural biopsy was the leading audience response. Tell us what you would be thinking and doing at this stage.
Well, thankful for the audience. But the audience is keying in, I think, on the one thing that's staring at us in the face throughout this case, which is that pleural effusion on the right. We keep getting more information about that. It was initially there was something to hone in on the lymphocytic predominance and as exudative, and then it became loculated and reaccumulating. It has required chest tube drainage. And while some of these other tests might lead to a diagnosis, we don't have as much information already to be concerned about a process in one of these other places like the heart. A PET CT might be positive, but it wouldn't be very specific at this in this patient, whether that's inflammation from infection or whether there's rheumatologic disease. And then bronchoscopy, I think that would be important if we thought that there was pulmonary infection that we haven't been able to find here yet, but not a lot in this case has evolved into systemic or, parenchymal infection. We haven't heard a lot about cough or sputum production. And we, on the CT scan, we didn't, I think we saw some ground glass opacities that might have been consistent with pulmonary edema, but not a lot else for infection, if I recall. Mm-hmm. And so pleural biopsy makes sense. We can miss pleural processes from the fluid, including TB and malignancy.
Mm-hmm. So the sensitivity of the tests we're able to send just from the fluid, you think, are not quite high enough at this stage with someone with recurrent exudative loculated fluid there that you need a piece of pleura to be more sure that there's what's going on? Yeah. We don't have a diagnosis yet for this pleural fluid. And I think at the end, by eliminating other diagnoses, including with the pleural biopsy, we might ultimately conclude that this is a unfortunate, exuberant pleural response after the cardiac surgery. But I wouldn't want to rest on that until I had some more information. So that's your diagnosis of exclusion. Is that compatible with it being 4 months out from cardiac surgery?
Yes, it can be present 4 months out. I would have to say that I'm not. I don't have enough experience by which to say whether this degree of loculation would be consistent. The lymphocytes can be consistent. The exudative nature of it can be consistent. But I think the degree of loculation is a little bit of uncertainty.
Okay. And interesting, I guess one last thing is the ground glass appears not to excite you. You sort of said, well, maybe a little heart failure. In my layman's way of thinking, when I hear ground glass, I am thinking that there's some inflammatory process and it might have pushed me to think bronch, but it sounds like not so much for you.
I think if there's a good picture for edema, we might veer away from bronchoscopy initially.
Mm-hmm.
When I think of ground glass, there's a classic differential sort of that we think about, and the radiologists remind us of often is fluid in the air spaces or interstitium. That fluid could alternatively, instead of just being a fluid like pulmonary edema, could be pus consistent with infection. It could be blood is another thing that can give ground glass. So even in the absence of infection, there can be a cause of bleeding in the distal air spaces leading to that. And then more unusual causes of ground glass can be a chronic process leading to fibrosis that just hasn't coalesced enough in order to give opacities or reticulations, consolidations or reticulations. And then, rarely in the setting of chronic renal failure, there can be metastatic calcification, and then rarely metastatic malignancy.
Okay, but it sounds like you're with the audience that you would be still looking at the pleura as the main culprit here rather than the parenchyma.
Yes, I mean, in terms of the parenchyma, there's one diagnosis that we were considering here, tuberculous pleural effusion, that sometimes can be diagnosed, indirectly, not directly from the pleural space, but by obtaining sputum samples or some airway sample. It's not the majority of the time that those samples will be positive, but if you get enough of them, say 3 or more, you can sometimes get a positive result in the setting of tuberculous effusion. And so in that sense, if we wanted to start with, we could start with trying to get expectorated or induced sputum samples and send them for culture. One of the things about bronchoscopy is that when we are considering infection, the airways are all connected. And if anything is able to get more proximally up to the mouth, then if there is an infection going on in the lung, then we expect to find it. And so starting out with expectorated or induced sputum samples is often a good idea. And if they're negative and you still are worried about infection, then proceeding with bronchoscopy.
Okay. All right. So you went through this, and I think in some ways the head scratching at this point, he's got a fairly unremarkable workup. We have not found the cause. He's still profoundly dyspneic and moderately hypoxemic. And you've gone through kind of what you would do next. So let's go and head toward the end. Patient had a short episode of VT, treated with mixilotine, converted to sinus. Cardiology was consulted. They gave him some nitro, I guess wondering whether this could still be ischemia. No improvement. He had a nuclear stress test that was negative for ischemia. LV ejection fraction was fine, and so that was and normal. He has a cardiac MRI. They're wondering, is there something going on in the heart itself that shows circumferential LVH, but otherwise pretty much nothing. And he has a SPECT CT looking for cardiac sarcoid. No evidence of increased FDG uptake, hypermetabolism of the lymph nodes, nodular hypermetabolism in the right pleura, and I'm guessing not diagnostic of cardiac sarcoid. And so we get to the end, and we basically have an 83, and so no pleural biopsy as far as I can tell, 83-year-old man with past history of multivessel coronary disease, had a CABG in October, and a PCI for a single vessel in February, and VT with an ICD, who presented now after 3 months of progressive dyspnea and now hypoxemia, weight loss, found to have an exudative and loculated pleural effusion, elevated inflammatory markers, and hypermetabolic mediastinal lymph nodes, whose diagnosis has eluded us with a fair amount of testing. And so we're up to a final diagnosis. At least the team believed that at this point they could make a final diagnosis. I don't know if you do, but why don't you go ahead and tell us how you're thinking about that?
Out of the data that you just showed, Bob, the PET scan, while we said was going to be nonspecific, I did find it interesting that the nodes were lighting up in addition to the pleura. Again, it's nonspecific, but it makes me interested knowing, what's going on. And although the team, I think, believes that there's a final diagnosis here, that's immediately eluding me. I go back to the bronchoscopy idea that you mentioned, whether there's a reason to stick a needle via ultrasound guidance into one of the lymph nodes, or again, a pleural biopsy. And we're still trying to connect the dyspnea to the relatively unremarkable, even though abnormal, findings in the lungs, pleural space, and in the heart. The inflammatory markers being up. There are cases after cardiac surgery, although this is 4 months out, where there can be persistent inflammation in the pleural spaces, a kind of serositis. And again, this might be an unfortunate variant here after cardiac surgery, where there is just ongoing exuberant inflammation. In some of these cases, NSAIDs are tried if the patient can tolerate them. Glucocorticoids, less studied. But the final diagnosis that the team may have arrived at this point, may be a exuberant pleural inflammatory process after cardiac surgery in the setting of negative infectious workup and malignancy workup, although incomplete, I think, without tissue, but with the elevated inflammatory markers and just the general history.
All right, so let's go with that and note that I think it may be a judgment call whether you feel comfortable that this is a fully negative workup, or you feel like you need a piece of pleura or a piece of lymph node to be sure about that. So let's see what the team did as they were thinking about it. So an interdisciplinary meeting was held, and I think that's maybe one of the lessons of this case, that may be the most valuable procedure of all, if you can actually get everybody in the same room, talk through the case between hospital medicine, cardiology, pulmonary, and rheumatology to discuss the persistent dyspnea and exudate. Cardiology thought coronary disease was unlikely given the negative stress test and lack of improvement after PCI. They thought heart failure was unlikely given euvolemia, normal filling pressures, and normal TTE. Pulmonary did not think there was obstructive or restrictive disease and thought that overall the normal underlying lung architecture and bedside PFTs ruled out significant parenchymal disease. ID thought an infectious disease etiology was unlikely given a negative infectious workup and lack of focal infectious symptoms. Rheumatology, given lack of extrapulmonary symptoms and negative serologies, felt a primary rheumatologic syndrome was unlikely. And so their diagnosis was the same that you came to, that this is actually an unusual case of post-pericardiotomy syndrome after coronary bypass surgery complicated by exudative and loculated pleural effusions, and essentially a diagnosis of exclusion with a whole lot of workup, not finding an alternative diagnosis. So with that, after extensive workup of the patient's dyspnea and recurrent effusion, it was attributed to that syndrome, as I mentioned. He was started on colchicine and ibuprofen with minimal improvement. He was escalated to pulse dose steroids for a 5-day course with significant improvement, pleural catheter removed without recurrence, transition to oral prednisone, and discharge from the hospital with plans for a prolonged taper. So we are joined by Sam Brusca, who's a clinical instructor and clinician educator in critical care cardiology, a new specialty for us at UCSF for the last 3 or 4 years, but one that's been incredibly useful, and including in cases like this. He's an expert in pulmonary hypertension and cardiogenic shock. He trained in his residency at Hopkins, did his critical care fellowship at NIH and cardiology fellowship at UCSF before joining our faculty. And Sam, let me bring you on and give you the podium for a few minutes to tell us about this syndrome.
Thank you. Great to be here as part of Clinical Grand Rounds. And I would just like to say, first off, what a master class in clinical reasoning. Even having read the case myself prior to preparing these slides, I thought that the diagnosis was somewhat in doubt, and I agree with all the assessment thus far. So I've entitled this quick talk, Serious Serosa. It's a primer on post-cardiac injury syndrome. And you'll notice that I am saying post-cardiac injury syndrome instead of post-pericardiotomy syndrome, because it's actually an umbrella term that incorporates various mechanisms of cardiac injury that can lead to a similar syndrome. I have no disclosures. Our objectives will be to outline a basic approach to chest pain post-cardiac surgery, to define post-cardiac injury syndrome and describe its proposed pathophysiology, and then to discuss some prevention, treatment, and potential sequelae. This being a clinical problem-solving grand rounds, I thought it would be best to start with my approach to chest pain after cardiac surgery. And I think the easiest framework to do so is to separate which diagnoses to consider in the early phase post-cardiac surgery as compared to the intermediate and late phase. Although this patient's main complaint was dyspnea, I do think that many of these diagnoses would also apply for shortness of breath. In the early phase after cardiac surgery, pain is very common, especially chest pain. This is typically post-sternotomy incisional pain, and then patients often complain of chest tube and pleural irritation. There are some other less common diagnoses postoperatively that we encounter in the setting of pneumothorax after pleural disruption, as well as myocardial ischemia. Acute coronary syndrome is quite rare after cardiac surgery, but we have to consider it especially after bypass, when there can be kinks to grafts or when coronaries are reimplanted as coronary buttons with aortic root repair. Pulmonary embolus comes to mind as well, although these patients are quite heparinized while on bypass, and so often pulmonary emboli are rare in that early period. And then we frequently see pericarditis pain postoperatively, but when it's immediate, hours to days after the procedure, it's often localized and due to direct pericardial injury or hemorrhagic hematoma within the pericardial space. As we move further away from the index surgery, the differential changes. We start to think of sternal wound infections, with the worst case scenario being a sternal non-union. There's also a syndrome of chronic post-sternotomy pain that is related to a neuropathic pain at the site of the incision. And then post-cardiac injury syndrome, which we'll be discussing more in depth, and actually chronic pleural effusion, which this patient ended up having. And these are actually thought to be somewhat interrelated, as we'll find out. So getting to my earlier point about this being post-cardiac injury syndrome, that's the umbrella term that differentiates various mechanisms of injury to the pericardium or myocardium that can induce an immune response. You all are probably quite familiar with post-myocardial infarction pericarditis, with an early form being termed just early post-MI, and then the late form commonly referred to as Dressler's. There's post-pericardotomy syndrome, as we saw in this patient, which occurs after cardiac surgery, and then post-traumatic pericarditis. And this can be with blunt or penetrating chest wall trauma, as well as iatrogenic or hemorrhagic pericardial effusions in the setting of cath or electrophysiologic procedures. Interestingly enough, post-myocardial infarction pericarditis is actually quite rare and is thought to be disappearing largely in registries in the modern reperfusion era. Post-pericardotomy syndrome is actually rare as well, with incidences in large registries being closer to 1%, whereas in smaller studies, it could occur as often as 15% of the time. Lastly, post-traumatic pericarditis, the incidence is unknown and it is likely quite underreported. So how do we diagnose post-cardiac injury syndrome? Well, first of all, we have to have a predisposing injury, and we mentioned the 3 mechanisms via which that can occur. And then, based on proposed criteria from some early clinical trials to prevent and treat post-cardiac injury syndrome, there have to be 5 of these clinical signs or symptoms present. The patient should report a pericarditic or pleuritic pain, positional or with inspiration. On exam, you may hear a friction rub. A pericardial and or pleural effusion should be present, although pericardial is classic in greater than 80% of the cases, and pleural effusion in more like 60% of the cases. And then finally, a fever without an other source should be present. Although those initial diagnostic criteria did not include elevated inflammatory markers, I do think in the modern era, most cardiologists would deem that that is necessary for the diagnosis with elevated ESR and CRP. Other things that would support the diagnosis are an expected treatment response to with anti-inflammatory therapies, as well as pericardial inflammation on imaging, such as with CMR, although that is typically done with refractory cases that are recurrent despite treatment. So post-cardiac injury syndrome is thought to be at least an immunologic disease. And the hypothesis of how it occurs is this. You get damage to mesothelial pericardial cells. This leads to release of cardiac antigens and the formation of immune complexes after some latent period. They deposit in the pericardium and pleura as they are similar serous organs, and this recruits leukocytes and leads to a serositis and clinically relevant systemic inflammation. This immunologic hypothesis is supported by that time latency that we mentioned, as it's more common weeks to months after surgery. The concurrence of the serositis in most cases in both the pericardium and pleura, and the fact that in clinical studies, you could predict the occurrence of this complication by the presence of increased anti-myocardial antigens. Moving on to post-cardiac injury syndrome treatment, you'll see that I've actually placed here an algorithm from the 2015 ESC pericarditis guidelines, and that's because we treat post-pericardiotomy syndrome very similarly. Initially, first-line therapy is with an NSAID or aspirin, as well as colchicine, and you can see the regimens here to the right. We typically will use aspirin often in these patients if they've had a coronary artery bypass or have some other indication for aspirin. Low-dose corticosteroids can also be used, although we typically don't use this first line, as steroids in acute pericarditis have been shown to lead to an increased rate of recurrence. Here now you can see the recurrent pericarditis treatment guidelines, with again us trying our typical colchicine and NSAID regimen again, followed by sort of a refractory dose of treatment with steroids. If a patient's course is refractory to steroids as well, we do consider anti-IL-1 therapy with anakinra or rilonacept, which recently was published in a New England Journal of Medicine trial. And then finally, for refractory cases, pericardectomy can be considered. As in many conditions, an ounce of prevention can be worth a pound of cure, and so this has been looked into. This is the first randomized controlled trial that actually looked at colchicine that was given empirically postoperatively on day 3 compared to placebo. The primary endpoint was the occurrence of post-pericardotomy syndrome, and the secondary endpoint was looking at a combined morbidity score based on the occurrence of hospitalization, cardiac tamponade, as well as constriction. And you can see that the placebo arm primary endpoint was over 20%, whereas in the colchicine arm, it was 9%, and this was significant. And the morbidity outcome hardly occurred in the colchicine arm at all. So why do we care about treating pericarditis? And I think the same applies to treating post-pericardiotomy syndrome. It's because we're trying to prevent constriction. We think about constriction when on exam, we see elevated jugular venous pressure. We see right-sided congestion, especially ascites. Kussmaul sign is consistent with interventricular dependence, and you get the JVP rising with inspiration, which is abnormal. And you may hear a pericardial knock on exam with that stiff calcified pericardium. However, often we use echo to make the diagnosis, or at least raise our suspicion for the diagnosis, again looking for markers of increased interventricular dependence. This will be seen with a septal bounce or with reversal of flow in the hepatic vein during expiration. We also look for evidence of restriction, in this case due to a stiff pericardium, with mitral inflow and then annulus reversus, where the lateral wall moves much less than the medial wall. So in conclusion, post-cardiac injury syndrome is a complication of cardiac surgery with uncertain incidence, but is likely under-recognized. It's traditionally a clinical diagnosis, but systemic inflammation is key to the diagnosis in modern practice. It frequently involves both the pericardium and the pleura. So this case that we just discussed is quite atypical in that the pericardium appeared spared. And then finally, it may be prevented with colchicine. And when it is present, despite colchicine, it can be treated like acute pericarditis. Thank you.
Great, thank you, Sam. That was terrific. We're a touch over. We'll go 1 or 2 more minutes. Nirav, why don't you go ahead and react to what you just heard and sort of any final reflections you have on the case. And by the way, just terrific discussion, very thoughtful. And one of the hardest things in medicine, which is sort of exclude a whole bunch of bad things to get to what is this diagnosis of exclusion. So what are your reflections?
Well, I learned a lot here from Sam's formal presentation of this syndrome. And I'll tell you that, there were a couple different names that you had for it. And just for the audience out there, you may not remember all the names of everything out there, but sometimes you can just think about processes, and sort of that's what I was doing, just thinking about, okay, well, there's some exuberant inflammation. I know there's these things that happen after cardiac surgery. I just don't remember exactly what they're called. So that's one thing. The other is that it's a atypical case here because of the lack of involvement of the pericardium. So I think that made it harder to hone in on the pleural space. And then it's interesting to conclude by asking ourselves, do we, at the end of the day, understand the patient's dyspnea and how we present it? And, I think if the effusion were there by itself, I wouldn't have expected that, like I said, to have a dyspnea, but perhaps we weren't appreciating the extent of the pleural involvement itself, the lining of the pleura, and that he may have ended up having more restrictive physiology, and that leading to the intense dyspnea than just from the effusion, that space-occupying effusion itself. So there was a tightening around the lung and the inability for it to expand well.
Great. Yeah, and I think it raises this issue of a diagnosed exclusion. How sure do you need to be that you have excluded everything? And I think you could make an argument here, do we really need a pleural biopsy to be 100% sure? But in many ways, what we've done instead is a therapeutic trial, and he did fine, which sort of elevates the probability that that is what's going on. You would have expected if we missed an infection and over time, obviously, if we missed a malignancy, it would demonstrate itself in other ways.
I think, and as you noted, another thing that really helped avoid a biopsy here was getting the multidisciplinary team together to discuss the case. And you get more than one person's lifetime experience there. And then you have multiple eyes also to follow the patient and their response to treatment and change course if needed.
Yeah, I think that may be the most important take-home lesson for the case. And one of the things I've learned from attending for many, many decades is you don't need it with every case, but if in many cases that is the key procedure is trying to get everybody in the room to talk it through for 10 minutes, and you accomplish things you could never accomplish in weeks of talking back and forth in the chart. So with that, we need to quit. Thank you, Nirav, really fabulous discussion. Thank you, Sam, really appreciate it. And thank you to our wonderful chief residents for putting the case together, Anna and Vidi, and look forward to seeing you all next week at Grand Rounds. Really appreciate it.